This is something when you are ACS, when you are going to suspect an ACS. What do you mean by an ACS? ACS is nothing but an acute coronary syndrome. Whereas there is one more terminology I would like to add on here is the coronary artery disease. You are going to have like includes in CAD, like you are going to have any old history of angioplasty done or any old history of CABG done. And it also even includes any sort of coronary artery disease. But in the case of an acute coronary syndrome, you are going to have the symptoms which are very acute, and they come up with an very they are quite specific to the coronary arteries. Now, the next one is whenever you are suspecting an ACS, it includes CAD also. Sometimes the CAD can have an ACS also. Yes. So when it includes now, then you need to assess whether it's a ST elevation or it is a non-ST elevation MI. If it's an ST elevation MI, then you are near to the diagnosis or you're up to the diagnosis that you can make up a call for either thrombolysis or you can go for a primary PCI. That part I'm just going to discuss later on. Now, if you're going to have a no ST elevations here in the ECG, but the history is quite confident, you are much confident about the diagnosis. Yes, this is something regarding the heart. What should I do? Yeah, you can have a troponin test. It is specific and same time sensitive to to your cardiac injury. Whenever in the case of an unstable angina, they are usually negative. And so these patients can be discharged with medical management. That you are troponin negative and you can have some minor depressions. And so these patients has to be discharged on medical management and then have a regular follow-up for further evaluation for this ischemic causes. In the case of a positive troponin and there is no ST elevation, you are dealing with a case of a non-ST elevation MI, there is a non-STMI. Here, you have to aim for like PCI within 72 hours in the patients with a 6-month mortality rate of more than 3%. This once again, I'm going to discuss a bit later on. Now, when you are coming to like ST elevation MI, are we dealing with an ST elevation MI? Yes. If your answer is yes, we have got the nice guidelines that whatever the cause of ACS is, like acute coronary syndrome, whether it's an STMI or non-STMI, you are supposed to give a loading dose of aspirin. That is 300 milligram of aspirin, and it has to be continued unless it is contraindicated. And the other things to be noted over here is that there is something called as a door to needle time and a door to balloon time. Door to needle time should be like less than 60. What is this door to needle time? What is this door to balloon time? Door to balloon time should be not more than 120. If this is door to balloon time is if there is an availability of an angiogram, of a primary angiogram and an angioplasty. If it is available, make sure that this patient benefits much better with an angiogram. Beware of certain things at the same time. If your center has got less backup, or sometimes we don't have a good backup, or sometimes we are in the centers that we don't have angiogram facilities, what to do? And you need to transfer this patient to some other center which is 2 to 3 hours away from the distance, even sometimes an hour distance. So you are now just going to lose the patient's myocardial cells. It is better that if you can thrombolize this patient because he's in front of you, right? So door to needle time is your thrombolytic time, that is less than 60 minutes, 30 to 60 you can say. It is as early as possible. I recommend as early as possible. But whereas at the same time, door to needle should not be more than 90 minutes. If it is beyond if it is beyond 90 minutes, make sure that you are going to thrombolize this patient. Now, depending upon this age, depending upon its ethnicity, depending upon its reperfusion status and all, and this outcome, expected outcome, you can have something like this medical management. Suppose there are certain centers even we don't have the thrombolytics available, then you can go with the medical management, like you can offer him a ticagrelor of a loading dose along with the aspirin, and keeping in mind with of this bleeding risk, because these are all antiplatelets. Then you have to consider if the bleeding is, the risk of bleeding is very high, like as per the Hasbled or the uh, other scores of this bleeding, you can add on a clopidogrel too. Then later on, this assessment of this cardiology function and this LV function and assessment of his mortality ratio and all can be evaluated. Whereas if you are in a center there where you have an ability to thrombolize, yeah, what has to be done? Yeah, if this patient can be thrombolized and you don't have an opportunity to send this patient out for a PCI immediately, for a primary intervention immediately, well, we have got a beautiful drug. We have got the beautiful list of drugs. I can say there are like thrombolytic, like nowadays we are using retiplase, tenecteplase, altiplase, a lot of drugs, and I think streptokinase and urokinase are still available, but they are less of this clinical use and more of academic purposes now. So make sure that whenever you're thrombolizing this patient, apart from this, try to give an antithrombin at the same time. So like you are going to give something like heparin or some other antithrombins, but still heparin is the better an option over here. And ECG has to be done after 60 minutes to 90 minutes to check that how the ST segment has got its evolution phase, whether they are coming down or that is still persistent, that is called as a failed thrombolysis. Or then in the case of failed thrombolysis, then by default you have to do a rescue PCI. Then you have to go for a rescue percutaneous intervention. Apart from this, if there is not much bleeding risk, you can also offer ticagrelor with aspirin unless it is a high bleeding risk. But if the bleeding is high risk, as per the Hasbled score is high, then I would like to recommend, as per the NICE guidelines, you can go with clopidogrel. Sometimes the aspirin alone can also work in the case with a higher bleeding risk because already we have thrombolized this patient. So as I've said you just now, that if there is a failed thrombolysis, don't try to repeat the thrombolysis because this can have a very drastic outcome sometimes. Now, after this, well, this is what we can do at an emergency level if we don't have any other setup. But luckily, if you are going to have a PCI facility available, right, 90 minutes to 120 minutes, yeah, that's good enough. You can do to balloon time as per the NICE guidelines. So you can do that. And if the patients has got symptoms like it is acute anterior wall MI or inferior wall MI or acute any MI, you have diagnosed it, then echo you did it, it is perfectly setting into that area of yes, this is some sort of segmental RWM is also present. Yeah, then after that you can directly take up for a PCI. Do we have a role of troponin over here? Well, I will tell you. The reason is very simple. Because if the patient presents to the ER within a span of 1 hour to 2 hours, there is no role of troponin. Even the earliest one, that is the myoglobin, sometimes take 2.5 to 3 hours for it to get elevated. Now, at the same time, now you have got a PCI facility available, you have got a good backup, you have got a good staff and a supporting doctor's facility. Well, PCI always stands good. At this point of time, you can do along with thrombosuction, you can remove the thrombus out. And the certain other indications here, apart from this, is like offering if presenting even in the case of 12 hours. Even in the case of 12 hours, if the patient has got 12 hours of pain, ongoing chest pain, ECG shows ST elevations, or in the case of a failed thrombolysis, you have got an indication of PCI. Consider if presenting more than 12 hours after symptoms and continuing myocardial ischemia and cardiogenic shock. If the patient is in cardiogenic shock, make sure that, and it is because of an ischemic changes, make sure that you are going with a PCI. But before this, if you are planning for a PCI, make sure that you do not give any other GPIs to this patient because it causes a loss. It causes a lot of bleeding on table, which is usually not better. At the same time, we can have a radial preferences. Nowadays, we are doing a lot of angiograms with the help of this radial access route, and their outcome is also better. And now we have got the drug therapy. What to do? Like we have given aspirin for everyone. We saw it was an acute coronary syndrome, but now we have got a facility for PCI. We're taking up this patient for the PCI. Now, what has to be done? Yeah, if you have a facility of PCI, as I have discussed earlier, you can offer this patient the one of the beautiful drug available is Pressagrate. Yeah, even though if along with the aspirin, if not already taking oral anticoagulant, like if the patient was not on any of the anticoagulant earlier, you can go ahead with this. If the patient was taking aspirin because of some coronary artery disease in the past, or the patient had an unstable angina or was under observation for unstable angina earlier, then as per the NICE guidelines, I would like to go with clopidogrel with aspirin. Now, at the same time, unfractionated heparin is a better choice in the case for bailout GPIs for radial access and bevaluridine with bailout GPIs if that is in the case of the rescue I'm talking about, if you're going for the radial access or for the femoral access. Now, then, well, we have gone through with this angiography. Then what? Stenting is required definitely. If a stenting is indicated, or sometimes there is a simple wet thrombus being there, a fresh thrombus form, it can be thrombosuction. If the stenting is required, offer a drug-eluting stent. We have got another 2 to 3 good drugs available in the market, which are already in the drugs. I think that are usually paclitaxel and all. They are nice drugs. They do their action well, good. But make sure that this is all in the case of you that they require a prolonged antiplatelet medication if you're going with a drug-eluting stent, right? Now, you have taken up a patient, but this patient has gone a multiple vessel disease. He has gone a multiple vessel disease. Then now what to do? Yeah, you can attend as many as arteries possible, or like 2 arteries are there. That's fine. You can attend them. You can have a stenting onto them, but make sure that if the patient is into the cardiac shock, or if you are doing something in an emergency, or if the patient was having like a prolonged ischemia, or a prolonged ischemic course of his time in the emergency, yes, try to attend only that particular visit. Well, in the case of an non ST elevation MI, just a moment. Right. In the case of this an NSTEMI, here we are going to have a troponin levels which were elevated, but we are not going to have elevations in ECG as we see in the ST elevation MI in that of the ECG of an STMI. So we have got like what's the difference between unstable angina and then an STMI? It's nothing more. It just wants something like an ECG. There you have got an ST depressions. You have got ST depressions in the case of ECG in the case of unstable angina, and in the case of an NSTMI, you have got uh, you don't have an elevations, but you are going to have an elevated troponin level. There is nothing but an NSTMI, but thrombolysis is not indicated. It is contraindicated. Now, how do we manage this type of patients? We are not going to do a thrombolysis. Then what? Now, for an initial antiplatelet therapy is to be offered, the same thing as I said, the aspirin 300 mg is to be the loading dose unless it is contraindicated. And an initial antithrombin therapy, you are going to offer here a fondaparinux, that is nothing but Fondarate, Fondaflu, so many are available. Unless they have got a high bleeding risk or you are going to take up for an angiography, still you find no ST elevations, the troponins are elevated, the patient is going into cardiogenic shock, you feel that there is some culprit vessel which is severely getting ischemic or stenosis, and you need to take them for an angiogram, well, we can have a double, or we can think it twice that whether this should be given this one synthetic heparins. But if not, if there is no reason like that, there is no plan for an angiography, if the patient's hemodynamics are good, you can directly go ahead with heparin, low molecular weight heparin, synthetic heparins, but as per the NICE guidelines, they do recommend synthetic heparins. Now, so you have to decide depending upon upon this bleeding disorders, because it can be like, it can be just ranging from hyperviscosity syndromes to something like Apla syndrome. You can have like anything else. All right, and make sure that once again you need to adjust the clotting factors also. You need to have the clotting time, and at the same time, and you need to have a look on the serum creatinine level also. Now, with this risk scoring system, we have got the GRACE score that it predicts usually the 6-month mortality and the risk of the cardiovascular events and its outcome, depending upon this clinical history, physical examination, 12-lead ECG, and this troponin I or T, either of them, serum creatinine, glucose level, and hemoglobin, etc. Suppose you have got a low risk. You have got a low risk, that is the predicted 6 months mortality is less than 3%. Well, you can consider conservative management without an angiography, but be aware of some younger people. They may be benefited with an angiography. This is some of the recent recommendations being done by the NICE guidelines. And to these patients, you can offer a ticagrelor with aspirin unless high bleeding risk. Consider clopidogrel with aspirin or aspirin alone for high bleeding risk. You have to consider it. Suppose if the patient has got an high bleeding tendency, better ticagrelor is avoided, and you can add on clopidogrel. There is also a good antiplatelet. So we understand that we need to have a dual antiplatelet and the third one is the heparin. Either usually it is the synthetic heparin. Now, before discharge, we need to consider whether it is going to be have like ischemia, whether this underlying ischemia will be there or not. Then next, followed by if you are going to have an intermediate or high risk. That is, you are going to have a higher mortality for 6 months. This patient definitely requires an angiography. This patient definitely requires a percutaneous indication. So if suppose if there is no separate indication for oral and anticoagulant, I'm sorry. So we can offer once again a pressagrelor or ticagrelor with aspirin. But if a person has got a separate indication for an oral anticoagulation, offer, this one clopidogrel, it still holds the better. But make sure that as in the last slide I have talked about that that whenever we are talking in terms of PCI, make sure that we are having that we are going to give pressagrelor. So in the same case, if you are having an intention, even in the case of this NSTEMI, that we need to go with a percutaneous intervention, definitely we would like to go with pressagrelor. This is what recommended by the NICE guidelines because of its better outcome. And during this angiography, if we come across any block or any stent, make sure that we are going to have a stent that is drug-eluting stent. And well, for the ages for 75 and above, we need to think for its pressagrelor. And at the same time, we need to have a look onto its weight also. Like the age is more than 70, 75, and the weight is less than 60 years. Better this is avoided. It comes once again as a contraindications, or we can talk about like relative contraindication to that of pressagrelor. This is some a gist of what both the slides is. Actually, I think we will be able to see it, but it is more or less the same thing. Right, in the case, like it is nothing but the same thing. Because why I'm talking about these medications here is that because we are not only managing these cardiac emergencies right away into our only emergency room, we may come across these type of patients who are sitting in an outpatient department. Like we can have a polyclinic. Even in the case of polyclinic, if some patients come, do we just refer them out? Like you just go and meet a cardiologist, or because we chest pain? Yeah, because once we have an ECG done, we understand that there is, like after taking an ECG and after evaluating its history and all, we can come to a diagnosis even if we don't have a troponin level. Yes, this can be an unstable angina. So at any part of the day, we can refer these type of patients to a proper cardiac center. I'm sorry. Yeah. So this is something like the Hasbled score, as you can see on the screens, like that hypertension, like abnormal renal and function. They have got 1 or 2, stroke 1, bleeding, level INR, elderly more than 65, drugs 1, alcohol 1, and maximum score is 9. So these are some of the scores I think we can see regarding the gray score. These are the 2 scores where we can see, and we can see in the bottom of our slides that we have something called the low risk, intermediate, and high risk. Low risk is one thing, and intermediate and high risk we have to deal about it. So this is how we do it. Like post discharge 6 months, 6 months mortality rate is something like this. Low is less than 3, and intermediate and high we were dealing with this slide. Like this on the left of your screen is usually the low risk, that is the previous 6-month mortality is less than 3%, and the intermediate and the high risk both comes with this previous 6 months mortality of more than 8, 3 to 8 and more than 8. So this is how we are going to manage. But in at this point of time, I'm not going to discuss like what all the thrombolytic agents we can give, where it is indicated and all, but still. But as a result, like we can have like these are some of those what do you say, the primary interventions we can do at our level, at the first level, or at the first phase of the patient's emergency, like the aspirin, as we can see over here, the aspirin 300 mg loading dose, followed by, if it is an unstable angina or it is an NSTEMI, you are going to have something like synthetic heparins. Or if we are in a plan to move for a PCI, yes, we are going to take up for an angiogram or angioplasty. This synthetic heparins are usually not given, GPIs are not given. They, instead of that, we can add some ticagrelor or pressagrel can be advised for them. But in the patient like who are not able to accept these because of this higher bleeding tendencies, well, aspirin alone can also work with it. Well, then it's up to you, depending upon the availability of your work, of your center. You have got a better thrombolytic facility, you can go ahead with thrombolysis, or you have got a PCI available over there, or a cath lab available there, you have got a PCI backup, then definitely it holds good. But be very sure that you have got a very good PCI facility available, you have got a very good cath lab facility available, because sometimes this can become a very bad nightmare too. Because sometimes we have seen a patients like we just take up an angiogram, and in the mid of the procedure, by some reasons they just end up in having some artery puncture and all, and then they also need to go from cath lab directly into the OT. That is, they may require a bypass graft surgery immediately. So make sure that you stabilize the patients. So our main intention of these myocardial infarction treatment or myocardial ischemic patients are there. We need to stabilize these patients, and these are the few drugs apart from the routine drugs recommended by the NICE guidelines in order to stabilize them.